Hello, I'm Blake Lesselroth, a clinician and associate professor at the University of Oklahoma School of Community Medicine. I'm joined today by my colleague, Kristin Rodriguez, director of the Tulsa Simulation Center. Today we'll be reviewing our work to date developing telemedicine training for undergraduate health professional education. Here are our learning objectives. By attending this learning activity, the audience should be able to list at least three topics important in a telemedicine curriculum, describe the teaching module developed and piloted in Tulsa, and identify at least two future applications of this work to interprofessional education. With the recent explosion of interest in telemedicine, we've seen an increase in the amount of published content. The associated proliferation of terms can be confusing, so here we've listed definitions based upon the peer-reviewed literature. This is by no means absolute, but it does provide a shared vocabulary for our discussion today. Telehealth is a broad array of remote healthcare services, including non-clinical services, such as provider training, administrative coordination, and even supply chain tracking. Telemedicine, by contrast, is the use of audio and or visual communication technologies to provide care over a clinical distance. This may include real-time conferencing, secure messaging, and store and forward activities. For the most part for today, we're going to focus upon synchronous or real-time care. As I said, there's been an exponential increase in adoption of telemedicine during the pandemic. These bullets on screen provide some examples of growth in the private, academic, and federal sectors. Certainly part of this was fueled by a relaxation in federal guidelines and how you can conduct telemedicine activities. These guidelines are likely to change in the future. But part of it was driven by consumer demand, and it's unlikely that this demand is going to go away. Therefore, professional schools need to teach to these new competencies. In putting together our project, we conducted an environmental scan. An important disclaimer here is that I focused upon what I know best, allopathic medical schools. I think this sort of scan is needed for osteopathic schools and all other health professional programs. What we learned is that more than half of the allopathic schools had included some sort of telemedicine training in the preclinical or clinical curriculum. What the numbers don't show is that there is a lot of variation in content, including the topics covered, types of instructional techniques, and the dosage of exposure for our learners. Unfortunately, until recently, Oklahoma was actually lagging behind other states. This is especially concerning given the needs of our state. We have a large, impoverished, rural, and underserved constituency. And teaching telemedicine is different than teaching bedside or in ambulatory care. Certainly many of the concepts translate, but there is a growing body of peer-reviewed literature indicating that there are novel learning domains, including website manner, patient-enabled physical exams, workflows with scripts, the tools and technology, of course, patient safety, and policy and governance. Also, this technology can link together disciplines for team-based models of care, and hence why we're talking about it during the Interprofessional Symposium. So to address the educational gap and to try to cover the broad range of topics, we outlined a strategic plan for curriculum development and spread. We're actualizing this plan as part of the True OK grant. That's the Tribal, Rural, Underserved Oklahomans grant funded by the U.S. Health Resources and Services, or HRSA for short. We envision a continuum of content that includes didactics, simulations, and practicums. This year, we've had the opportunity to develop and pilot several didactics and one simulation, which my colleague Kristin will talk more about. Kristin?
Thank you, Blake. This year, we had the opportunity to pilot our telemedicine curriculum within an interprofessional module focused on mental health. The morning session included didactics on telemedicine, adverse childhood experiences, or ACEs, and trauma. Our telemedicine didactic emphasized the importance of patient safety and introduced the basic tenets of website manner. In terms of safety, we felt it was critical that our learners understand the importance of knowing the location and privacy of their patient, as well as recognizing that not all patient visits are appropriate to conduct via telemedicine. Website manner encompasses how we present ourselves during a virtual visit, including maintaining eye contact with the camera, speaking clearly, using a talk aloud protocol, and effectively using body language and nonverbal cues. We developed one ACEs scenario for delivery via simulated telemedicine visit during this session. The scenario had a patient presenting to their scheduled telemedicine appointment with a chief complaint suitable for a telemedicine visit. The simulations were performed in small groups of 5 to 6 interprofessional students and 1 to 2 faculty proctors. The students were pre-assigned a specific piece of the interview and provided the patient history via virtual door note. Half of the groups were reminded to adhere to telemedicine best practices as taught in the didactic section before being instructed to interact with the patient in a round-robin manner, serving as a single provider. During the simulated encounter, students were expected to achieve several outcomes, including measures specific to telemedicine and the ACEs and trauma-informed care content. Overall, the simulations went very well. We did not experience any technical issues. Most groups met the ACEs and trauma-informed care learning objectives, and half of the groups met both the ACEs and trauma-informed learning objectives, as well as the telemedicine learning objectives. We learned several things from this experience. One, faculty buy-in and experience with telemedicine is critical to session success. The groups that were not reminded to use the telemedicine skills taught in the morning session did not achieve those learning objectives. Two, didactic content must be evenly weighted when multiple topics are being addressed. The majority of the didactic content focused on ACEs and trauma. Insufficient time was allotted for the telemedicine content. And three, reminding learners that this experience was formative multiple times throughout the simulation introduction, large group pre-briefing, and small group briefing reduced learner anxiety so they could focus on practicing the skills taught in the didactic session. We developed an assessment tool for our SPs, our simulated patients, to use to assess the learners as a group regarding their communication skills, knowledge of ACEs content, and adherence to telemedicine best practices. As I mentioned earlier, there was a definite difference between the groups that were reminded of the telemedicine objectives in their small group briefing and those that were not. The groups with the reminder met all of the telemedicine objectives upon SP assessment. So to summarize, telehealth and telemedicine are very quickly changing the way we deliver healthcare services. Working within this new climate requires learning new communication skills, physical exam techniques, and adapting workflows. OU has the opportunity to teach, model, and evaluate new competencies. It's very clear that simulations are vital to the success of this new curriculum. Our pilot was successful, so we now have the opportunity to adapt our scenarios and scale for enterprise deployment. So thank you so much for your attention and interest. Please don't hesitate to reach out to us using the email addresses on your screen. We are very interested in your feedback, insights, or collaborative opportunities.